Good evening, everyone. I am Dr. Kristine Andujare, an orthopedic resident from the Medical City. Tonight, I will be presenting a case entitled Rise of the Non-Tuberculous Infections, Osteomyelitis in a Pediatric Patient. My consultant co-author, Dr. Candice Lim, and I have nothing to disclose. Beginning with the case, we have a 3-year-old male presenting with the current infection in multiple areas of his body. Within his first year of life, his first abscess developed in the right axillary area following a BCG administration. Incision and drainage of the abscess was done, specimen was obtained, and sent for gram stain and culture studies before being started on any antibiotic therapy. Culture studies yielded negative result, treatment was completed, and patient had improved. Since this first episode, the patient developed abscesses in various parts of his body, the scalp, the forehead, and even the right eyelid. Each episode of abscess formation was treated with oral antibiotics. 1 year and 5 months prior to admission, the patient became persistently febrile and was admitted at a local hospital where a blood count was done, revealing white blood count elevation. He was then treated with empiric antibiotics, clindamycin, which was eventually shifted to ceftriaxone, with the primary considerations at this point being Langerhans cell histiocytosis and pulmonary tuberculosis. Both bone marrow aspiration and TB workup done at that point yielded negative results. 1 year and 4 months prior, the workup continued. Skeletal survey was done, showing cystic bone irregularities in the right parietal and frontal bones, left clavicle, left scapula, left radius, both distal femur, and the left fifth metacarpal bone. There was also some sclerotic changes seen in the left mandible. This then confirms that the ongoing pathology appears to be multifocal. The lesions were eventually evaluated, assessing which of these was most accessible for tissue sampling. And the patient eventually underwent bone biopsy of the left radius, which came back with the findings suggestive of chronic osteomyelitis and negative for any tumor cells. The patient was then started on clarithromycin and their HRZE as well as prednisone. 3 months prior, the patient became intermittently febrile. He was then admitted and was started again on ceftazidime and amikacin, but the fever continued to persist. At the ninth hospital day, the patient's right hip and gluteal area was noted to be swollen, and he was then started on clarithromycin. Radiograph of the hip was done, showing lytic lesions on the right iliac crest. Ultrasound done at that point revealed presence of an intramuscular abscess, prompting administration of clindamycin and indicating surgical debridement. Patient was also obtained gastric aspirate, which was sent for gene expert, which was eventually showed to be negative. However, due to the financial constraints, the patient opted to transfer to another institution where they can have the procedure and subsequent treatment be given. 2 months prior, the patient was transferred to an institution where he was able to undergo the incision and drainage and debridement of the right hip. Intraoperatively, they noted that the abscess in the gluteal region was tracking towards the iliac crest. Specimen was obtained and sent for GSCM, which eventually yielded negative results. Post-operatively, radiographs and CT of the pelvis was done, confirming osteomyelitis. At this point, the patient was referred to a hematology oncology specialist who had suggested for a repeat BMA be done due to the persistent increase in WBC. This repeat BMA appeared to be negative also. However, the specimen was obtained during the procedure was subjected to TB studies yielding positive growth for non-tuberculous mycobacteria. However, the laboratory was unable to speciate which mycobacteria was present, and the patient was managed as a case of presumptive extrapulmonary TB and started on HRZE with streptomycin. Clinically, the patient improved and was sent home. 1 month prior, the patient developed a generalized rash, which was thought to be an allergic reaction to the medications, prompting for the HRZ and streptomycin combination be stopped and gradually reintroduced. Eventually, the medication was shifted to HRZ with amikacin. 2 weeks prior, a mass was noted to be growing on the scar of the hip and gluteal area. The mass was noted to have to be increasing in size with development of erosions on the overlying skin, as well as a draining sinus. At the time of examination, the patient also had some bony prominence in the skull, and as well as the right upper eyelid. He also had multiple cervical lymphadenopathies, hepatomegaly, and a palpable spleen. Specimen was obtained aseptically from the lesions on the hip and was sent for another round of TB cultures, which yielded non-tuberculous mycobacterium avium complex or MAC. With being able to identify the specific NTM species, this patient was subsequently referred to a pediatric infectious diseases specialist who revised the regimen being given to him now to include azithromycin. He also indicated to have an immunodeficiency workup be done and a formal referral to an allergologist immunology specialist. HIV workup for the patient and both parents were also done and all negative. Immunodeficiency workup was also normal, and the pediatric allergologist immunologist cleared the patient for any primary immunodeficiency disorder. Clinically, the patient continued to improve, and the plan of care included completion of the anticox as well as azithromycin regimen for 2 years, with monitoring to include the clinical presentation of the patient, the skeletal survey, and the CBC. On follow-up, the patient continued his follow-up post-operatively with the pedia ortho, and pedia IDS specialist. Monitoring of medications was done, the clinical presentation of the patient was being monitored, and the laboratory tests also continued to be done. Annual skeletal survey also done, and all pointed towards the patient continuing to improve. These were the radiographs done during the pre-treatment skeletal survey, showing us sclerotic changes in the left mandible, the left clavicle, the glenoid fossa, in the 4th to 8th rib, as well as in the left radial shaft. At 2 years, a skeletal survey was done. This time it showed us improving or resolved lesions, as well as no new lesions from the said survey. Clinically, we now have a 5-year-old male who completed medication regimen for 2 years and is fully ambulatory, functional. No new skin lesions was noted, and the previous scars already healed well. Here you can see him already attending regular school. So just a short discussion on nontuberculous mycobacteria. The incidence of nontuberculous mycobacteria NTM infection is increasing. In developing countries, 0.3 to 0.87 cases per 100,000 children present with any of the associated clinical syndromes: lymphadenitis, skin and soft tissue infection, pulmonary infection, and disseminated infection. NTM is known to be ubiquitous in the environment and has been isolated from water sources, unpasteurized dairy products, soil, plants, and even animals. Usually, this would present with cellulitis with a draining sinus, as well as recurring skin lesions precluding underlying presence of a draining sinus. Tissue diagnosis usually clinches the diagnosis after thorough history and physical examination is done. Antibiotics, singular or combination, remains to be the cornerstone of management and is dependent on the sensitivity to the isolated microbe. Surgical interventions just indicate once infection is found to be deeper, involving deeper subcutaneous tissue, tendons, and even the bone. However, despite the number of cases increasing, there still seems to be a delay in clinching the diagnosis and commencing appropriate treatment. And again, the same is even more true for your NTM osteomyelitis. So just a little information, your NTM osteomyelitis has some known risk factors. This usually occurs after environmental exposure for nosocomial exposure, be it penetrating injuries, post-surgical infections, and whatnot. This is usually rare in immunocompetent hosts, and HIV is commonly associated with disseminated infection, especially in those with CD4 count less than 100. MAC is one of the most common pathogens reported in diffuse HIV-associated NTM osteomyelitis, and most cases of NTM osteomyelitis are caused by rapidly growing NTM following trauma. Other noted risk factors for this are traumatic injury, use of systemic glucocorticoids, cardiac surgery requiring sternotomy, living in a tropical rainforest, and literature also describes that most sources of NTM infections are environmental, with tap water serving as a major reservoir for most isolates. BCG vaccines are also identified as a risk factor for development of NTM infection, but mostly for skin and soft tissue infections. However, development of SSTI puts a patient at risk for osteomyelitis. Evaluation and diagnosis are limited due to the limited information present regarding NTM osteomyelitis. A high index of suspicion, including thorough history and PE, knowing the risk factors, evolution of lesions, previous medical history of the patient, any presence of recurrent skin lesions resistant to medications, the environmental history of the patient, as well as nutritional status, could lead to the high index of suspicion, leading us to do further workup that would clinch your tissue diagnosis. In conclusion, there is an increased incidence of NTM infections, with NTM osteomyelitis as one of its manifestations. Though there's limited information available, NTM infections are increasing. Though rare, NTM osteomyelitis appears to be one of the syndromes by which NTM infection manifests. Though several factors have already been identified to be associated with clinical syndromes that NTM presents with, there still remains limited information on NTM osteomyelitis, resulting in delay in both diagnosis and treatment. High index of suspicion appears to be the greatest tool a healthcare provider may have to afford appropriate care to a patient who may have NTM osteomyelitis. The role of doing a thorough history and physical examination, be it BCG vaccine, history of persistent and recurrent cutaneous infections, or any of the identified risk factors for NTM osteomyelitis, information should be elicited from the patient to arrive at a diagnosis and subsequent treatment as soon as possible. Finally, knowing that NTM species are easily isolated from the environment, particularly from tap water, it may be prudent to pay particular attention to these infections as they may also pose as a public health concern. This, coupled with the reality where access to medical care and clean, safe water are both limited, where mycobacteria may be endemic, it is important to recognize these unique situations and the challenge that comes with for solutions to be developed. Referral systems could be made and put in place so that specialized care necessary for cases like this, be it the specialists or the facilities or the laboratory facilities that may run these tests, may be more accessible to patients who may need them. This is now the video for a patient posted with consent from the parents to be shown to this audience. Now we have a 5-year-old male, active, already attending school. And medically, he hasn't presented with any of the skin lesions he previously presented with. These are my references. Thank you.